Hello, this is your brain on drugs, and this is the punk rock psychiatrist. We're going to talk about adverse effects of stimulant medications. So let the bad times roll. Like, what do we do about the downsides of these medications? So, and I mean, if I can be honest, it's like all medications have downsides, right? So, and think some people jump on the downsides of some medications more than other and say, oh, we should never use this because of this and stuff like that. But like honestly, I would say patients tolerate these medications better than pretty much any other psychiatric medications that I prescribe. So that's not to say that people don't have issues with them, and that's what we're going to talk about today. And I think this stuff probably affects the pediatric population more than the adult population. I don't see as much of this in, like, I've treated tons and tons of adults and only like a handful of kids. So the I'm going to go over a list of some of the most common side effects, and then we're going to dig deep on some of them. We're not going to cover them all today. Substance abuse and cardiovascular disease are like bigger topics, and so I'm going to probably set aside separate show for those. But we'll go over some of the other ones today. Insomnia is a big one. 10 to 30% of folks report that on these medications. Dental stuff like grinding of teeth, dry mouth, loss of appetite and weight loss, so 20 to 30% loss of appetite, 5 to 10% weight loss, irritability and anxiety, 5 to 10%, rebound. We'll talk about what rebound is. Tics, 7%. But the potential for suicidal ideation exists. Headache, 20 to 30%. Honestly, headache is a side effect of pretty much every single medication if you look on there. I mean, especially anything that's like affecting the central nervous system. All right. Circulation problems in the fingers and the toes. This is kind of like a Raynaud's phenomenon type of deal where you get like numb, cool, painful sensations in your fingers and toes. Seizures, pretty rare, but could happen. And then priapism, that's like an erection that will not go away. I've never seen seizures or priapism, to be honest, but those are some of the more dangerous things that like are pretty rare, but if they happen and they're on these medications, I would consider them as a potential cause, but I would not give them um, because of risk of this. Now, if somebody has a seizure disorder, that's something that you're going to have to take into consideration when you're prescribing this. But just fear that they might have one when they haven't would not be. So let's talk about sleep and insomnia. This is probably one of the big ones that people talk about there. These are stimulants, right? They're kind of like amphetamines, speed, right? They are amphetamines. People take these to stay awake. People abuse them to like, a lot of people abuse them to study for a test, and they may be getting less effect from the focus and more effect from just being able to stay awake all night to study, right? So people, have been abusing stimulants to stay up for a long time, but if you're not abusing them and you're trying to use them to treat your ADHD symptoms, you don't want to not be able to sleep that night, okay? But like a lot of stuff, where this it can be hard to say, is this a side effect of the med or is this just the ADHD? People with ADHD have worse sleep. And so, for every patient out there that has difficulty sleeping on the medications, there's a patient out there that sleeps better because they're on the medications, right? Because ADHD causes sleep problems. I think having all that stuff kind of like going on inside your head all day and maybe in the evening as well, it it makes it hard to sleep. And if you're more focused and you've accomplished tasks and your brain is more focused on what you want to be working on and one thing at a time, it's going to have less scramble in there, and you may be better able to sleep. If especially if the stimulant effect is worn off, um, hopefully you would then sleep better because your symptoms were under control. Okay, so the, folks with ADHD also have difficulty waking up in the morning. So it's like they have difficulty going to sleep at night, and then it's like they can't get out of bed in the morning. Oh, they take the stimulant that can help wake them up. So in both ways, you can, whereas insomnia is a side effect of the med, it also could be fixed by the med. Okay. But if it is caused by the medication, or if that is suspected, what could we do about that? Right. So some non-medication treatments. And a few of these are things that I would suggest with like pretty much any adverse effect to pretty much any medication. And these other adverse effects we're going to talk about. You can always try lowering the dose. The dose may be too high. You may be on a medication that's too long acting. You may be taking the medication too late. Are you taking it like first thing you wake up? Are you waiting a couple hours? Right. So if you can take it earlier, if you can take a lower dose, if you can get on a formulation that's not as long acting, and you may be like, but I need that effect. It's working for me later in the afternoon. Well, it might be keeping you up at night. So we might want to try to give you something that you may have to sacrifice control of symptoms later in your afternoon in exchange for being able to sleep. Not everyone's going to have to make that trade off, but that's something that could be considered. And it's trial and error. Make the change, see what happens. Did they have a positive result after making the change? Then keep it. If they didn't, then maybe that wasn't the issue. All right. So it's also, of course, important to keep a consistent bedtime, and especially when we're talking about kids and adults as well. When you have ADHD, you're just often disorganized and your life is disrupted, and you're not going to bed at the same time. You're not waking up at the same time. Like you're probably more likely to have poor sleep hygiene. And so that's, anytime there's sleep problems, the first thing you should be doing is that. And folks with ADHD have a harder time with that. So, and if you're not doing that, all these other techniques that we might be using could be all for naught. So, and with a kid, you have more control over what they're going to do at night. Make sure the TV or the screens are off at a particular time. Make sure they're in bed at a particular time. They're brushing their teeth at a particular time. Get a routine down. Okay. Um, and then remember when we talked about the amphetamines, we can use vitamin C, 1,000 milligrams, to kill the med, right? It gets it out of your system faster. So if you're on amphetamine, try taking some vitamin C in the evening. Half an hour later, you're excreting that drug and it's not in your system. That might help you sleep. Okay, so those are some techniques that you could use to help with the insomnia. Um, let's talk about some medication techniques. Now, this might be contrary to what you're thinking. You know, sometimes, I mentioned that lowering the dose may help with this. It actually may help to increase the dose. Okay, so that's another thing that could be tried. Because remember, what I said in the beginning was that these medications can actually help with insomnia. So maybe the insomnia this patient's having is not a result of the drug, it's a result of the ADHD, and it's undertreated on what they're on now, and perhaps a longer acting or a late, having a short acting dose later in the evening might actually improve sleep. All right. And then you also think about this, like the levo amphetamine is more of the kind of like cardiovascular system increasing. So like increased heart rate and things like that. Whereas the dextro is doing more of the focusing. And so maybe switching to another medication like a Vyvanse or something like that could help. All right. And then some other things you could try: melatonin, especially with kids. This is like one of the times that melatonin is hit or miss, and it's also hit or miss whether you have a good product or not. And it's do you have jet lag is one thing that we know that it can help with, and then ADHD is another one that it could help with. And then clonidine, now that's an alpha 2 medication. Sometimes we use something like that for treating symptoms of ADHD, right? We use like Intuitive, etc. We'll often use like Capve at night. So adding that medication, not only can it treat the symptoms of ADHD, it's a sedating medication, so that could be used. And then, of course, we've got medications like trazodone and mirtazapine that can be used. All right, so that's insomnia. And now let's talk about the dental issues. So, bruxism, otherwise known as teeth grinding, once again, lower the dose, that sort of stuff you should try. You can always try changing medications. If this is another thing that kind of applies to all of them. If you're on methylphenidate, try an amphetamine. If you're on amphetamine, try methylphenidate. Try different meds. But if nothing's working and the med's amazing and it's really helping with everything, but you've got this teeth grinding issue, you don't want to mess your teeth up. So go to your dentist. You can get a mouth guard for that. So that would be what I would suggest. And I'm not a dentist, so they may have some other suggestions. I would just go there. You'd have to go there to get the mouth guard anyway. So yeah, I would go see your dentist about that. And you may not even know you're doing it. If someone's in the room, they can often hear it. So that may be how you and you may the patient that's taking the medication might wake up with jaw pain. That could be a sign that you're having teeth grinding, um, things like that. But it can wear down your teeth, and our teeth are one of the few things in our body that don't grow at all. They're like not alive. I mean, of course, like the part on the inside of your tooth is alive, right? I forget what that part's called, but like the part like in the middle of your tooth is alive, but the enamel, the outside hard part that is exposed to the world and chews food, it doesn't change. Like you don't get, as far as I'm aware, you don't get new enamel. I know that like fluoride can help maintain it and things like that, but like a lot of people don't realize your bones are alive. They can change. You can grow new neurons. Probably your teeth are probably some of the only things that you're going to be stuck with your entire life. So it's like so incredibly important that you take care of them, because if they get messed up, that's forever, right? So there's a plug for dentists. Um, Next one, dry mouth. Yeah, I've talked about dry mouth before when I talked about the anticholinergic medications. Dry mouth is not just annoying, but potentially really harmful and can lead to cavities. So you do want to do something about it and not just be like, oh, this is just something I have to deal with and I guess I'll tolerate it because the medication is working. No, you actually do need to be aware that this could cause some medical issues. So very important to have good dental hygiene. You want to take extra care with that, with if you have dry mouth, like also avoiding sugar, because like remember, dry mouth, it's going to make it more likely that you're going to get cavities. So not taking in sugar, another excuse to not eat sugar. You want to decrease your risk of getting cavities even more since you're at increased risk. A sugar-free gum. Sometimes those sort of things can help with salivation as well. Using a humidifier at night, because sometimes you might wake up with a sore throat as well. So that's unpleasant. Of course, making sure that you're drinking enough water and avoiding alcohol, caffeine, and tobacco. Those things can all lead to dry mouth. So we don't want to also be doing something else that could be making the problem worse. So that would be my suggestion on how to handle dry mouth. And here's a big one, the whole appetite growth restriction, that stuff. So I've got a lot of information on this. So first we'll talk about appetite suppression, and then we'll talk about growth being affected. And there we're just talking about kids, because adults are already fully grown. We don't have to worry about that. But for appetite suppression, and this is especially important in children, because they are, kids need adequate nutrition more because they are growing. And so what you want to do is give the medication either after they had a meal or at the same time, before the medication is kicked in. So I often advocate for eating 2 meals a day. I think the whole 3 meals a day thing is a scam, by the food industry to get us to eat more and spend more money. So if you're not a breakfast person, like I'm not a breakfast person, you might want to become one, or your kid might need, breakfast becomes more important because they're probably barely going to touch their lunch. And like, don't get upset with them when like they don't touch their lunch. It's so normal. They may not eat anything for lunch. And so because they're not eating lunch, it's just that much more important that they get the calories in before the med starts working and after it wears off. So like breakfast and dinner become like really, really important. Um, and then, just get whatever they can get in during lunch is important, but like it's hard, especially you're not there, they're at school, they're not hungry, they feel a little bit nauseous if they eat too much, they just don't want to eat, they don't eat. Okay. And so you want to get like nutrient dense, calorie rich food in, um and try to avoid the empty calories, like, oh well, stuff that's like sugar and simple carbs, like, because that's just unhealthy in general, right? And there's some thought that it could make some of the ADHD symptoms a little bit worse. It's a little bit controversial topic, but like it's not great food. And so you want healthy, nutrient dense, calorie rich food. All right. um and then I'll give you a couple examples of those. So like, and this would be for anyone, like, I go to the gym and stuff, I'm trying to put on muscle mass. Our brains have these set points, and I feel like it does not want me to get any heavier than 180 pounds, and it's like really difficult to get over this mark, and you really have to like eat more, right? So things that can help would be olive oil, any kind of fat, but olive oil is like the healthiest, best fat that I can think of, and I like the taste. You can like dip bread in it and things like that. There's just like a lot you can do with it. See, it doesn't take a lot to have a lot of calories. So you can even drink it straight. Like I'll do that, but like a lot of people wouldn't want to. Cheese is another good option. Put cheese on everything, and there's so many different kinds of cheese. You've got so many different options there. Some Parmesan cheese, or some melted cheeses, or so, like cream cheese probably is the least one that I would go for, but not a terrible option if you're trying to gain calories. Adding cream to like sauces and things, or sour cream. I've started putting sour cream in guacamole at night, as a, because avocados also have a lot of calories. So I'm like, well, maybe that'll help. Nut butters are a good option. Full fat yogurt. So like those are some healthy options. To and then if there's other healthy things like fruit and things like that that the patient enjoys, don't limit it. When they feel like eating, let them eat. All right. So um, the one thing you do have to kind of think about is that we talked about this earlier in an episode, several episodes ago, about how high fat diets can actually affect um, the medications and how long it takes them to work. So it can actually delay that. And I'm actually going to mention that here in a second. When I get to the next slide, I'll talk about all different things about how food can affect how the meds work. And so if you're increasing fat content, or you're having that fat for breakfast, if you're having it for dinner, not so much a problem because the med's wearing off. But if you're having it for breakfast, it could mean that the medication takes longer to work. So like, high fat diet affects some medications more than others. More so on an extended release amphetamine medications, but it's everything could react differently, and different people could. So keep that in mind. We don't want the medication to take longer to work if we needed it to work. So think about that. And then trying to do more of like protein is a good option, because the fats maybe affect how the medication works. And then like a lot of simple carbs, like those are just like not good for us. And so proteins and things like that can be good to use as well. So let's talk a little bit more, let's dive in a little bit deeper on like how food can affect how the medications work. So the food may increase oral absorption of immediate release tablets and chewable tablets of methylphenidate. And so you want to administer them 30 to 45 minutes before meals. So like, take the medications first, because the food could increase its absorption, and then it's going to kick in too hard and not last long enough. there's all different kinds of things. Sometimes you might have delayed effect of the medication working. Sometimes it may make the medication work more quickly. So like here's food in general can affect immediate release methylphenidate to make it absorb more quickly. And then, like I said, the high fat meal can delay the onset of peak concentration for Focalin, Quillavant, as in long acting meds in general. Um, and then there's certain medical conditions like children or patients with decreased GI absorption or intestinal resection. So they've got some sort of, you know, GI issues that affect how they absorb in general. Um, for Concerta in particular, they may not get the full benefit. You know, some of these meds, think about how some of them work. Some get absorbed later in the GI tract. There's the one that has the delayed release, and it's like the pH is changed and things like that. And so some of those things we use to our advantage may be a disadvantage for folks that maybe don't that they have some disease in that area of their gastrointestinal tract, or they've had that part of their gastrointestinal tract removed. And so you've got to take that into consideration as well, that a particular medication, the way it works, may affect that patient. So, keep that in mind. And then remember, like antacids and acidic medications affect the amphetamines as far as, excreting them quicker or more slowly, right? So, just a reminder, the acidifying agents, so like acidic foods, vitamin C, and urinary acidifying agents can lower amphetamine plasma levels, and like we can use that to our advantage to get rid of the drug, if they're having problems at the end of the day. And then alkalizing agents, so that's stuff that makes your pH more basic, like sodium bicarb, and urinary alkalizing agents like some medications like acetazolamide, some thiazides, some blood pressure stuff, can increase amphetamine plasma levels because they decrease excretion. And so keep that stuff in mind. So like the reason why the drug may not be working may not be the drug's fault or the patient's brain's like not matching well with it. It could be like the way they're eating, or something else that they're taking in. And these are not the typical drug interactions that I think about, like the CYP enzyme interactions. These are like uh, uh, different types of interactions. A lot of the other psychiatric medications I deal with, they don't have these kinds of interactions. This is kind of unique to the stimulants. All right. So that's, how appetite can be affected, and then how meals can affect how the drug works. But then we've got, this is like a big issue that everyone gets like really like worried about, is that kids are not growing. Okay, this is like a super controversial topic, but it's actually like really not a problem. And I'm going to go over that with you. All right, like a lot of people don't want their kids on these medications because they think that they're going to have their growth stunted and they're going to be short, and that's going to affect them for the rest of their lives. All right, so let's dig in on this. There's been a lot of studies that have kind of shown that this is not really something you should be that concerned about. It's something that we need to be aware of, because sometimes we need to take action about it. But the good news is we can easily avoid this problem. Okay, so there was a 2-year prospective multimodal treatment of ADHD. This is a study with stimulant, showed a 1 centimeter per year growth deceleration. So that means the kids 1 centimeter. That's so there's 2.5 centimeters in an inch. So that would be like maybe about 30, like a third of an inch, a little more than a third of an inch per year that they're not growing, that they would be. So like that's scary, right? Like that sounds like, wow, that's going to add up, 6 years, that's like 2 inches, that's a big difference. Okay. So, a little more context on that. So there's another study that showed a small but significant differences in height were found between children with and without ADHD, but the differences were no longer apparent by late adolescence. So this is the idea that early on, kids are affected, but that they catch up, right? So They don't necessarily grow as quickly as other kids um, earlier on, but their end heights are virtually the same. Okay. So when we followed children into adulthood, they found basically no impairment in height. Okay, so that's the good news. This you may notice this phenomenon happening. It's not like it's in our imagination, but when they go through growth spurts and things like that, they will often then grow more to make up for some loss earlier on. And remember that loss is pretty small as well, so they're only going to be a little bit behind early on, and then they're going to catch up. So here's another one. This is from 2010. It's called A Naturalistic 10-Year Perspective Study of Height and Weight in Children with Attention Deficit Hyperactivity Disorder, Grown Up Sex and Treatment Effects, from the Journal of Pediatrics. So they basically took males and females and they looked at controls and they looked at ADHD and they looked at height and weight. And like when you compare the control with the ADHD, they're virtually the same. Okay, so like there's no statistical difference between these. And then as far as like weight loss, because like height loss is one thing, weight loss is another one. Um, we can see this, and in some children, it's more of a problem than in others. So interestingly, kind of how I said that like having difficulty sleeping can just go along with ADHD. There's actually like weight things that go along with ADHD as well, and you can get them on both extremes. So like you can have people that like have obesity problems because of their ADHD, like their AD just like the behavior that happens as a result of the ADHD makes them, they're more impulsive, they're going more for the quick high, and they end up choosing the wrong foods and they end up becoming obese. But on the other hand, a lot of folks with ADHD are just kind of at baseline, don't have good appetite. And so that's just something that goes along with the illness. And then they tend not to eat as much anyway. And then the stimulants may not be actually the reason why they're not eating. It could be part of the ADHD, or it could be contributing and making things a little bit worse. So when we get concerned is if they have a growth trajectory that crosses two major percentiles, and the percentiles that we look at are like, this is like what, when we look at growth charts for kids, for those that don't know this, if you've ever seen that, you can look this up and see pictures of it. And you've got like where are you in, like, related to people your age, right? If you're in the 95th percentile, it means you're taller than 95% of people your age. And if you're in the 5th percentile, it means you're taller than 5%, which means 95% of people are taller than you. And so if somebody starts off in the 5th percentile, and of course 5% of people are in the 5th percentile, right? If you're already in the 5th percentile and you're on these medications and you just stay in that 5th percentile consistently, then we don't think of this as a problem because that's just your baseline, right? But say you start off in the 50th percentile and you go down to the 10th percentile, right? So you've crossed two. You've gone from 50th through 25, now down to 10. Then we start to get concerned. It's like, oh, they were in the 50th, but they've dropped two percentiles. Like if you go down by up or down by one, that just is, some kids grow at different rates than others. You may start off a little bit bigger and then slow down, or you may start off smaller and then catch up. But, if you're crossing two, we start to be concerned. What's causing this? It's not necessarily ADHD medication. There could be other causes, but you certainly want to see your doctor. And this is stimulant medication is definitely going to be high on their differential for what could be going on here. And so probably would recommend holding the medication if we're concerned, like, that they're underweight, and see if that makes a difference. Right. And if it does, another controversial topic have been around of those that treat ADHD is the idea of the drug holiday. Right. So that would be like not taking the medication. A lot of folks, they're just like, you need to take it every day. This is an everyday disorder. If you get off of it, it makes you unstable and you have to take it every day. I am not in that camp. I'm and the thing is, I'm in the personalization camp. I think there's probably folks where that's the case, right? So it's like it's not an either or. It's a like, or it's, it's like sometimes for this person I do it this way, and with another person I do something else. So there might be the patient where, you know, having drug holidays is a bad idea, but then there's other folks that it can help, and not just for this, but also like I advocate drug holidays because oftentimes people get tolerant of the meds and they become less effective, and then if they take some days off, it can kind of like stave off that tolerance so that when they do take the med, it maintains its efficacy, right? Because, what do you want to take it every day, but it like doesn't work that well? Or do you want to take it sometimes and when you take it, it works well, but then you have to deal with it not working well on other days? I'd rather go with that if that's the trade off. If you can take it every day and it works great every day and you never have a problem, then great. But if that's not you, then having some days off can help with that. Now, when we're talking about weight loss, oftentimes we can like eat, well, when your appetite's suppressed, which is definitely an option, or not an option, it's definitely an effect that happens from these meds. They will then be able to eat normally on those days, and so you're going to want to pick what days work best. So like typically that would be weekends or holidays, and oftentimes like summer. So you've got, like, especially in the US, we have these long summers, which that's a completely other discussion. I think, it's a remnant of the farming past, and it's outdated and it's destructive to have school not in session for that long. In Japan, where I live, they're never out for more than 4 to 5 weeks at a time, and they actually have a couple of 4 week breaks per year rather than just like one big long one at the end. So but that does, if you have this issue, give you an opportunity to not be on the medication for a significant period of time. Now, just because you're not in school doesn't mean you don't need the medication. um, ADHD is, when we're talking about kids here, it affects more than just your performance in school. It affects your social relationships. You can form poor social relationships, being talking out of turn and being impulsive and things like that. That can make, that turns people off. That can affect your ability to make friends and maintain relationships. Um, it, it can be very destructive in the home. They're not doing chores, they're not behaving, they're driving their parents up the wall. They can't get anything done. So I would advocate for not taking drug holidays if you don't need to. A lot of people, they do the drug holidays regardless of whether they need to or not. And I would, be against that. I would say, if they do well on the meds, taking them every day, and we're not having any issues where we need to take days off, do not take days off. But if we have a reason to take days off and it's like something we need to do, and like, their weight is a problem and they're crossing percentiles on their growth chart, then yeah, we're going to have to deal with this. Okay. So that as anything, it's always an, what's going on in this particular patient situation and what's the best way to respond to that. All right. So I have a lot of appetite and weight, and I think in adults I don't worry about this at all. I've never noticed it's a problem. I mean, most adults eat too much to begin with, and most of them, their appetite is barely affected by these meds at all. Like, these meds work completely differently in adults and kids as far as like how they tolerate them, and I just find that adults just have way less issues with them. um, and and like they have insight into the fact that it's benefiting them much more than kids do. Kids just tend to like not like this at all, and but they often need it because it can increase your risk of, I mean, long-term stuff. I mean, we talked about this before. Like, if you have uncontrolled ADHD, your likelihood of drug abuse, risky sexual behaviors, getting STDs, getting pregnant, um, dropping out of school, uh, not going to, not having a steady job, drug abuse, those can all be a problem if you have ADHD that's uncontrolled. And so I think people think of it as like a performance enhancing drug that like, you know, gives someone an unfair advantage at school, that like, oh, they weren't doing well and then they take this drug and it makes them do better. And that's not fair. I want my kid to be able to do better too, because, they didn't need this drug. And it's like, one, that other kid was capable of it, but they have a disorder and we're helping them with that. And they have the intelligence to actually do better. We should be able to give them the opportunity. These medications don't make you smarter. These are not intelligence enhancing medications, right? They they help clear out the clutter so that you can perform at your optimal when you're someone who's not doing that. All right. They don't make you smarter. They don't. I mean, it's this idea that like, oh, it just keeps you awake and it keeps you to focus better and all. It helps you focus when you can't focus, right? If you don't need this and you're a high performer, it's not really going to do anything for you. It's just, it's not really going to help. I mean, would it help you stay up all night? Yes, but you're not going to retain that information. If you're not sleeping, you're not going to retain this information anyway. So like, that's not something that you should really be striving for. All right. So it is important to kind of have these available for those that need them, and to try and like get through these hurdles of issues they may be having. All right, so let's move on to our next topic, irritability and anxiety. This can take two forms: on the meds and when the meds are coming out. And it's important to make a distinction between that. So are they getting the irritability and anxiety during the time that the medication is like on board, or are they getting it at the time it's wearing off? If it's when it's wearing off, that's what we call rebound. So the rebound is the meds coming out of our system, and that transition away can cause some irritability, anxiety type of symptoms, and I see this in adults as well. So um, that's an important distinction, because how you're going to react to it's going to be different. If it's happening while the drug is on, the likely it's that the dose is too high, and if it's happening when it's wearing off, it could be that whatever medication regimen we're on, we're losing medication too quickly, right? It's dropping down too fast. We want something that's going to taper off slower than what they're on currently. And so let's kind of dive in a little deeper on these two. So let's talk about the irritability, anxiety. Um, we also want to make the distinction as to whether is this happening because of the medication, or is this happening because they have a coexisting mood disorder or anxiety disorder. Like there's a lot of overlap. Like a lot of folks with ADHD have a comorbid depression, anxiety. And so if it's a separate issue, we want to treat it separately. Therapy, SSRI, whatever, right? So that's an important distinction to make. Is this because they have a separate disorder or not? And then, of course, if it's happening at peak concentration of the drug, let's try reducing the dose. Switching if they're on short acting, longer acting is typically better for most patients. And for both this rebound issue and the irritability, anxiety while the drug's on, long acting can help with that. We want a smoother curve. Like, so if you listen to the last few episodes I've had, I talk a lot about that curve. How fast is the drug coming on? How fast is it dropping? And if we have a couple of peaks, how steep are those peaks? We want even rounded peaks. And go back and listen to those episodes, and I talk about which medications have smoother peaks. Okay. So irritability, sadness, increased activity as the medication wears off is more common with short acting meds that are taken twice a day. So that's another thing. It may be that like if you're taking two short acting meds, you're getting that peak. And so like that going up, not only coming off too fast can cause this issue, coming on too fast can cause this issue. So we want that to be as smooth as possible. All right. And then caffeine can worsen this. So if you take stimulants and caffeine at the same time, that could actually exacerbate this problem. So if you're using caffeine, look at decreasing the use of that and see how that affects this issue. All right. So let's talk about the rebound now. Right. So it's similar symptoms, kind of this irritability, anxiety, but it's happening when the drug is wearing off. Right. So I already kind of talked about this. if it's a long acting agent, sometimes increasing the dose of that long acting agent, it pushes that like plasma level up, and also it'll last a little bit longer. You may get a bit smoother taper if you have more in your system. um, Adding a short acting medication at the end of the day, so as it's wearing off, adding a short acting med. So like you've got an Adderall XR, you get this rebound, add a little bit of IR, a tiny dose, a little 5 milligram IR at the end. That can help boost the levels of that drug in your system as the XR is wearing off, to make that curve go down smoothly. So that is another thing you could consider, right? And then of course switching to a medication that has a smoother curve. And some examples, the patches tend to have a bit smoother, because they're absorbed. The way they're absorbed is they're more slowly absorbed through the patch rather than a pill where it's just kind of hits you all at once. Also, like lisdexamfetamine, because of the way it's metabolized by the red blood cells, makes it a little bit smoother. The surdexmethylphenidate, the newest one, Saris, that one is kind of similar to lisdexamfetamine, though remember it's metabolized in the gut versus the blood cells. There's probably a bit smoother curve going on there. Those liquid XR technologies, with the different sizes of the extended release beads, gives you a smoother curve. So like maybe playing around with, like, I think the cheapest option is to go with that small dose IR at the end. But if this isn't working, maybe you go for one of these other formulations. So that is what I would suggest to deal with the rebound stuff. And then let's talk about tic disorder. So if you don't know what tic disorder is, it's kind of a disorder where people will have like quick movements. Sometimes it's like a muscle spasm looking thing, or it's like a repetitive. It's something it's like a urge to move, and they can't resist the urge. And it might be like, it could be in a hand, or it could be anywhere, facial expression. It could even be like an action that they take. It's mostly uncontrolled, and it's something that's comorbid with ADHD. So there's an increased risk of just having this tic disorder if you have ADHD. And there's this thought that the stimulants can cause tics or make tic disorder worse. Let's dive in on that. So the FDA put out a warning on psychostimulants for those with tics, and it was based on limited data from the 1970s and 1980s. More recent studies have not shown a link between psychostimulants and tics. However, there is a link between ADHD and tics, which I mentioned a second ago. Up to 50% of kids with tic disorders also have ADHD, regardless of whether they're using a stimulant or not. It's the same thing. You might have insomnia because of the ADHD. You might have tics because of the ADHD. And I mean, there was another thing I mentioned that you might have because of the ADHD. I mean, you can have irritability, anxiety because of the ADHD. Interestingly, a lot of these side effects of the drugs are also signs that you're not giving enough med, right? So I think we think, oh, the med's causing this, let's lower the dose. Well, it could be this isn't the med, this is the ADHD, and actually increasing the dose could help. And so if lowering the dose doesn't work, you might want to try increasing the dose. Okay. So, that's another thing that we have to consider, is that this is just the ADHD causing this. Or it's just the fact that they have tic disorder because they're at an increased risk because they have ADHD. All right. So what you want to do is, let's do a little experiment. Try days without taking medications. See if the tics are happening. If they go away on no medications, then reconsider the risk benefits of taking the med. And if not taking the med is the answer, we have other medications that we have not yet talked about that would be options for those patients. The non-stimulants, which is what we'll get into once we get through all these adverse effects, probably maybe one more episode or so. We'll talk about what those options are, so that we have other options that may work for these patients. But also, of course, just because they get it on amphetamine doesn't mean they'll get it on methylphenidate. So like, this is not like, oh, they got this on one stimulant, we can't give them any other stimulant. Try another one. All right. And like I said, here's another thing. Just like I said, you could actually treat the insomnia with a higher dose, or the anxiety with a higher dose. Well, you could also treat tics with a higher dose. That works for some folks. So it may taking a stimulant might actually make the tics better in those that have ADHD. So methylphenidate actually has more data for treating both conditions, tics and ADHD, than amphetamine. So that might, if they have both disorders, just kind of independent of meds or whatever, methylphenidate might be a better choice. The use of an alpha 2 agonist, so that's something like intuitive, right? Like guanfacine, clonidine, things like that, with or without a stimulant. So instead of or in addition to, sometimes we add a stimulant and a non-stimulant together. That could be helpful. And then atomoxetine, the norepinephrine reuptake inhibitor, we have not yet talked about that one. It's not known to worsen tics at all, so a switch to that medication may also be considered. All right. And then let's talk about suicidal ideation. There is a warning from the FDA, came out April 2015, but not a black box warning. As you'll mention, like a year ago, or if you'll remember a year ago, we talked about the black box warning on the antidepressants, which is a class warning. I really don't like this. So it's like any new medication that gets approved as an antidepressant. So like the ketamine medication, like was Esperado, right? Is that, I always forget these things when I have to think about them off the top of my head. But right, the nasal spray ketamine, it doesn't work anything like other antidepressants do. There are no tests on whether this causes suicidal ideation or not, but because it is approved as an antidepressant, all of a sudden it gets the black box warning, right? And so I really don't understand the reasoning behind that. That just seems insane to me. And so because these medications, even though they have a lot of similar mechanisms of action, they don't have the black box warning. And I don't necessarily think that's a bad thing, because I don't think the antidepressants should have the black box warning either. But it also doesn't mean you're out, that you're safe. Like, antidepressants can increase the risk of suicidal ideation. These meds can too. I'm not I wouldn't even necessarily say that one's better or worse than the other one. I've seen it on both. And so the fact that this has an FDA warning and they have black box warnings, that means nothing to me. I'm thinking about this for everyone taking any kind of psychiatric medication, to be honest. A suicide assessment is always important, and anything that's messing with the brain could do any number of things. And so this is always something that you kind of have to keep in the back of your mind. It's not something that would prevent you from giving the medication, but it's something that you need to monitor. All right. Because remember, these meds work very similar to bupropion, which has the warning, and they don't. See, it really makes no sense. So that's just something that you definitely need to be thinking about. And there is actually the warning on there, just not the black box warning. All right. Also consider that these meds can be used to treat depression. All right. So that, and why, it could be that they're depressed because they're ADHD, because of the consequences of having ADHD, and having their ADHD treated helps with the depression, right? Like all the psychosocial stuff going on because of the disruption in their lives is causing like problems for them. Maybe their risk of going to jail and things, like huge problems could be happening. Increased risk of car accidents, right? Like that can cause you to be depressed. Not being able to function well in your relationships causes stress, so treating the ADHD can help with these depression symptoms. But it's possible that these actually work kind of similarly to the way a lot of antidepressants work, and so they could actually just be helping depression alone. So we often use these off-label, usually added on to a antidepressant. But I've given people this as their sole treatment. I mean, I think I mentioned this several episodes ago, but I've given this as sole treatment for bipolar disorder, and I think people would think that's completely nuts. I wrote a paper on it. Read it. I think there's certain people that have bipolar disorder that don't respond to or need a mood stabilizer and can have their symptoms relieved by psychostimulants. I think in the psychiatry world, we really don't have any objective data at all to determine what disorder somebody has. We try our best, but we really don't. We don't have any lab tests, blood pressure measurements, uh, physical exams, scans. I know some people think those spec scans help. I don't believe that at all. I think it's complete nonsense. I don't think it gives you any information. So the genomics, some people think we're looking, we want objective data, but it doesn't exist. Um, Maybe one day we'll find it, but we really don't have anything. And what we do have doesn't help us figure out what to do. It's not, we don't have enough to actually use it intelligently. So, and I'm talking about diagnosing disorders. And I mean, the DSM is completely made up. And it's like they validate a lot of stuff in the DSM by saying we had a panel of experts evaluate the patient and they all agree this is what they have. And it's like, yeah, but what criteria are they using? They're using the DSM, right? Like just because somebody has depressive symptoms doesn't mean they have depression. You might have ADHD when you have depressive symptoms. You might have bipolar disorder when you have ADHD symptoms. Like we've just kind of created this manual, and it does its best. Like we have to have something. Like I've said this before, like I knock the DSM, but it's like, what's the alternative? I mean, there are some people that have come up with some alternatives, but like we don't. I mean, there's not really a great solution out there. We have to do our best, but I think we have to understand the limitations of what our diagnostics for psychiatry are. And so then we have to be open-minded to say, you know what, this antidepressant didn't work, let's use an antipsychotic. That didn't work, let's use a psychostimulant. Let's use a mood stabilizer. Let's try all different. Let's go with the most likely thing first, but let's not rule out that this thing that we think might not work will work. You have no idea. Sometimes it does. And so it's maybe not for everyone. That's why it's not in the guidelines, but like we don't really know what our disorders are. We don't really know how to, we have a general idea. And I think for the majority of patients, the way we diagnose them works fairly well. But there are large numbers of people for which we're not able to really come up with a very solid diagnosis. I mean, if you interview a patient, make a diagnosis, and give them a treatment, and they get better, then nothing to worry about there. Did you get the diagnosis correct? Probably, maybe. Does it matter? They got better. Who cares? Right? But if you make a diagnosis and then you give them a treatment and they don't get better, maybe the treatment's wrong and maybe the diagnosis is wrong. And there's no way to know, right? Try something else. Like you're going to try a couple of things that go against that fight the disorder that you think they have. And when this is not going well, consider they may have something else. I mean, it might be something medical, which would be awesome because that's a lot easier to like have objective data on. Or it might be another psychiatric disorder. And, the DSM just doesn't characterize this particular patient's symptoms very well. Like they may be a patient with ADHD that presents with mostly depression symptoms. Or they may be the opposite. They may be a depression patient that presents with mostly ADHD symptoms, and that they may not meet the DSM criteria for the disorder that like the treatment that they take actually fixes. And so I think you really have to be open-minded. And I think because these are scheduled to substances and they have like this negative connotation of their use, people are a lot more willing to give someone an antidepressant or an antipsychotic or a mood stabilizer, and a lot less likely to give them a benzo or a stimulant, sedatives and stimulants. And so they may not even get the opportunity to try the treatment that was going to help. And so, humble yourself, realize that sometimes you may get the diagnosis wrong, and it's not necessarily your fault because they're fitting perfectly into this category. But that doesn't mean that like the criteria you're using to give them diagnosis is valid for that patient. All right. So that's why, I mean, this tangent happened because I was saying, don't negate the fact that these drugs can cause suicidal ideation. Any of our drugs can cause almost any side effect that all the other ones can, and almost any drug can treat almost any disorder. I mean, the one thing I would not do, or there's a couple. One thing I would not do is treat a legit bipolar disorder with an antidepressant and nothing else. Like that's something that like I would that's like kind of would never do that. That would never make sense. Now, do they really have bipolar disorder? That's something to question. But they have bipolar disorder. I'm not going to treat them with monotherapy depression antidepressant. And if somebody has a psychotic disorder, I'm not going to treat them with a psychostimulant. Those are two things I'm just not going to do. Everything else is on the table, right? I mean, I guess if they have a substance abuse disorder, I'm not going to give them an addicting substance that they don't need that they're abusing. That would be another one. I'm sure you could think of some other stuff, but like pretty much anything is on the table for anything that's going on, other than a couple of exceptions. And even though they're not FDA approved for that, or generally accepted for that, that doesn't mean that that's not what's going to work for this patient. So keep that in mind. These are really good medications. And the one thing I like about them is they tend to be the most well tolerated, and they work the fastest for sure. And they actually improve symptoms the most. And so, man, if I can give someone a stimulant and they get better, that is just a relief. I don't want to give the impression that these work for everyone and everyone should be on stimulants and on nothing else. I'm just saying, if you weren't considering a stimulant, you might want to consider a stimulant, especially if you're not getting anywhere. All right. One more slide for today's podcast, and then we'll talk about some other adverse effects next time. I just want to go over kind of the official contraindications and caution warnings for these medications. Contraindications are things that we pretty much never want to do, and then caution are things that you can do, but like probably not. So the contraindications are hypersensitivity. That's for every medication if they have some sort of poor reaction allergy or something like that. Within 14 days of an MAOI, these are on the list that can increase the risk of your hypertensive crisis. So we don't want to give these with MAO. That would be another thing we don't do. We don't give MAOIs with medications that put ourselves at risk of, not hypertensive crisis, of serotonin syndrome. We don't do that. We don't combine, like, serotonin syndrome is something that's always in the back of our minds, but almost never happens. And we can combine lots of serotonergic agents without issue. But when an MAOI is involved, that's when we really get concerned. So that's another no thank you. Luckily these meds are rarely used, but sometimes, like linezolid, methylene blue, rarely used, but they are MAOIs. Have to take that into consideration. There's a lot of things, go back and listen to my MAOI episode if you want to learn more. And then this is severe uncontrolled cardiovascular disease. This is actually only in the Canadian warnings, but I think it is important. We're going to talk about cardiovascular stuff next time. But if you've got like really severe cardiovascular disease, taking a stimulant is probably a bad idea. And I'm talking about like structural abnormalities, cardiomyopathy, serious arrhythmias, coronary artery disease, hyperthyroid, which typically we could get that under control, but if it's not controlled and we're having high blood pressure as a result, not a good idea to try and make it worse. Glaucoma does not mix well with this. Pheochromocytoma, extremely rare tumor. And if they have moderate to severe hypertension that's not well controlled, we probably don't want to give them a stimulant on top of that. Let's get that. But if we can get that hypertension controlled, we can do that. But if it's currently not, don't give them a stimulant. Okay. So some of these more severe uncontrolled cardiovascular diseases, we have some risk for cardiovascular disease that we're going to talk about next time. So that would be something I would be aware of. And then for caution, if they have uncontrolled seizures, the risk is still low, but you're going to want to dig in to figure out if you want to do this or not. If they have hepatic and renal impairment, you can do it, but you need to look at the specific drug. You need to see, is this something I should alter the dose on? Is this one that's not good to use? Should I use it? Would another one be better? Make sure you're looking into that. If they're currently in an agitated state, let's wait till they're not in an agitated state. The motor tics and Tourette syndrome. So we didn't talk about Tourette syndrome, but that's a syndrome where tics are a part of the disorder. And remember, that's kind of questionable, but it's listed. If you look at the list under caution, they will list that. Um, I already gave you my thoughts on that. Untreated bipolar disorder, I've given you my thoughts on that. Generally, no, but like in some patients, I have found that it actually makes whatever disorder they have, whether it's an ADHD that looks like bipolar disorder or some bipolar type 10 that they have. I've seen these things type 3, 4, 5, that looks like ADHD. These medications can actually help with some patients, so don't completely rule that out. And then recent or unstable substance abuse. So we're going to talk about substance abuse as well in a future episode. And in many cases, these control ADHD, which makes it better and less likely to happen. But in some patients, they're going to abuse these substances. So caution needs to be taken. All right. So that's all the adverse effects we're going to talk about today. I'm going to get into cardiovascular risk, some other stuff next time. I want to thank you for joining me today, and I will see you next time.